Patients come in because they've got a problem. At this point in my career, I mostly see arthritis of either the knee, hip, or shoulder, or I see rotator cuff tears of the shoulder. And then kind of as a secondary part, just by being an orthopedic surgeon, we see fractures. When people come in with arthritis and or rotator cuff tears, I think the main thing what I want to get across to them is this can be treated. It's very common practice to treat conservatively first, so not everything needs surgery right away. And when it does need surgery, we will have exhausted all the conservative measures to make sure that, to give us the best chance that surgery will work. We live in a retirement area of Florida, and a lot of our patients are in their 70s and 80s, some are in their 60s, a lot of retirees playing golf and tennis, and knees are frequently the first thing to go. People come in with knee arthritis, virtually 10 to 20 patients a day. We do a lot of cortisone injections, we do a lot of gel injections, we do some physical therapy and bracing, and when all else fails, we do knee replacements. And one thing that's we're noticing is that there's some better results with partial knee replacements. If patients are a candidate, if they've only got certain types of disease in their knee and they're young enough and active enough and meet certain other criteria, they can get a partial knee replacement, which in some ways is a much better option than a total knee replacement. Well, partial knee replacements can be done outpatient. If somebody doesn't have a lot of comorbidities, if they're not very diabetic, if they're not morbidly obese, and they've got good exercise tolerance and they move around frequently, partial knee replacements can be done outpatient in a surgery center. It's quicker, the surgical operating time is quicker, the recovery time is quicker, the pain control is quicker, the incision is smaller, and people return to function much quicker. So in the end, it is just a globally quicker, faster, less painful operation to do. One of the hallmarks of arthritis is that the knee may start to buckle, either bowing out or bowing in, knock-kneed or bow-legged. And when that happens, it can cause the inner part of that joint, meaning if it's concave, if it's bow-legged, it would be the inner part of your knee. If it were knock-kneed, it would be the outer part of your knee, but it would cause that part of the knee to wear even faster, and it's a vicious cycle that the bow-leggedness causes more arthritis, the more arthritis causes more bow-leggedness. And one thing that we can do in certain people is put a brace on their knee to hold them from getting worse, and in some cases treat their pain and their arthritis just like that, non-surgically. Well, the classic signs of arthritis are morning stiffness and startup pain. You get up in the morning, you put your legs over the side of the bed, you sit there for a few minutes wavering back and forth, stretch them a little bit, you take your first couple steps, and the more you walk, the better it gets. That's morning stiffness. Startup pain, similar to morning stiffness, is people always tell me, I go to dinner with my grandkids, we're at the restaurant, after sitting there an hour and a half or 2 hours, I can barely get up, I have to stretch my knees, I have to stand there for a minute, sometimes I even sit back down, but then when I get going and I start moving, then it gets better. And those are the kind of the classic hallmarks of arthritis. Morning stiffness, startup pain, and the more I use it, the better it gets. Well, partial knee replacements historically weren't very accepted. People have been doing them for 20 years, and in a lot of cases they worked, but the technology was inferior. The types of metal and plastic they used to make them were also inferior. The data had not come out yet as to whether people were doing better or not, so we didn't know if they were actually working. It seems like in the last 18 to 24 months, some of the data is coming out that they work very well. Some of the companies have improved their technology. The instrumentation for the doctor in order to make the certain cuts in the bones and to put in the pieces is much more user-friendly. And then lastly, and in some cases most importantly, the anesthesia chemicals that we use have been documented well in a way that both the anesthesiologists with the surgeons have created very routine, acceptable protocols by which there's less nausea, less pain, adequate pain control, quicker return to function, ease of surgery. And with the pain control protocols the instrumentation improvement, and the data showing that they work, this is a recipe for a beneficial procedure. This is something that is going to work in certain people. A lot of patients come in and say, I want a partial knee replacement, and if they're morbidly obese or have very uncontrolled comorbidities like diabetes or smoking, they're not a candidate. Certainly not a candidate to do it outpatient. We can do a partial knee replacement and keep them in the hospital, but that's no different than really doing a total knee replacement. So we're starting to see some patients now that can get this done outpatient, and they're much happier, much quicker return to function.